So what is the proportion of TB burden in India? It is written over there. Please. Yeah, please sit in front. Why? I don't understand why. If you have bad vision, why you are sitting over there? Please come sit in front. The screen is for you only. You are supposed to read. If you are not able to see it, then what is the point of view of people? Anybody else having a bad vision? Anybody else having a bad vision? No. Yeah. No, just tell me. That is world population. What about India? What is the incidence? Yeah, read. It is not mentioned over there, madam. It is mentioned in that map. Go. Go see. It is for you people only. Go see. That map is there, no? So how much it is? Or is it 300 to 400 or 200 to 300? What is the color of India over there? India is almost olive green, right? 100 to 200 per? Correct. Come back. So these are the new cases of TB. Okay. No, madam, you have a problem. No, please sit over here only. Bring everything. No, please. I will be asking you again. That's what I'm saying. And you will have to keep on reading. And this is for everyone. If anybody has a problem in reading it, please come and sit in front. I'm not going to ask again. There is no point in keeping the chairs vacant. So what is our national goal for TB? This was discussed last time, right? We are just summarizing it again. Sorry, yeah. NTP, what is that? Sorry, what? Yeah, if you know, you talk louder. Tell me, madam. Program. Okay, so what is the aim of that program? So how do you quantify end of TB? See, last time also I have told you, no, every government policy, every health program will have some end goal, which has to be achieved by the end of completion of that program. And it is defined in the program itself, that where we are today, where we want to be at 5 years or 10 years down the line or at particular time point. You people know Millennium Development Goals, right? MDG. No, you have not read PSM. There was something called Millennium Development Goals. Huh? What was 2 days back? There was something called World Environment Day, right? Everybody knows about that. What is Paris Accords? Almost all the major governments have signed that accord, right? Regarding environment. The emissions have to be reduced to so and so. See, these things are there, no? These things nobody can teach you. Even if I tell you last time also I told you, and nobody among you remembers that aim itself. This is something which you have to read on yourself, by yourself, and find out. Otherwise, we coming over here and just telling you that these are the goals, this is how we are going to achieve it, not going to make sense, because you people are never going to remember it unless and until you people start putting efforts. What is the rate of TB, incidence of TB in developed countries? You had gone there, no? See, India is a developing country, right? Everybody agrees at least that one, or not? So we are aiming to be a developed country by what year? What year? What is the stated goal of Government of India? 2047. So by 2047, we are aiming that our standards of living should be equivalent to what is currently there in developed countries. So developed countries have an incidence rate of TB of 10 to 20 per 1 lakh population. So now we are aiming for that only. That has been defined as elimination. Okay. See, you need to know the end of the race, right? Otherwise, how you know whether you won or lose? There should be some objective criteria, right, to define whether you achieved something or not over such a long period of time. So that is the goal of NTEP. Okay. This is the PSM part. This is not yet orthopedic part. Okay. So what else is there? How many extrapulmonary TB cases are there? हाँ बोल भाई जोर के बोल 18 to 20%, correct. So what is extrapulmonary TB? What are the types of TB? I think this also we had discussed last time, right? Types of TB. Correct. What about extrapulmonary? Can you mention some sites of TB? Pulmonary means lung TB, right? So extrapulmonary means without lung, which doesn't involve the lung, or which involves lung along with some organ else. So bone, correct. Brain, correct. TB encephalitis is there, no? Tuberculosis meningitis is also there. There is an entity called tuberculosis encephalitis meningitis. Then think intestinal TB is there or not? It's there, right? Then lymphadenitis, tuberculosis lymphadenitis, it's there or not? So it's an extrapulmonary site, right? And skeletal tuberculosis. Done. Sit. So 18 to 20% of the patients will present with extrapulmonary tuberculosis. Okay. And how many will present with both pulmonary plus extrapulmonary? Some people might be unlucky enough to have both pulmonary and extrapulmonary TB, right? There will be few unlucky ones among ourselves. So what is the proportion of those patients? It's written over there. 10%. So start reading and telling. At least I should know that you people are reading and giving some attention. Okay. So 10% of the patients newly diagnosed TB will have both pulmonary as well as extrapulmonary tuberculosis. So relatively speaking, extrapulmonary TB is not that common. Okay. The most common thing is pulmonary TB. The reason being, what is the reason? Why lung TB is most common? What is the mode of transmission of TB? Droplet infection, right? So which usually the first organ which the bacteria will come in contact with? Lungs. That's why pulmonary TB is more common. Extrapulmonary TB is usually spread by blood. Okay. So this is one diagram of how it spreads. So usually most of the cases will have pulmonary TB, which would either heal, okay, or body will wall off, and then there will be hematogenous spread of the tuberculosis bacilli, and wherever they were able to find ground to grow, they will cause disease over there. So for skeletal tuberculosis, what is the most common site? Spine, correct. Why? See, everything should have a reason, right? Yes, madam. Yeah, stand up. There is a topic. You. Yeah, it is related to vascularity only. You are on the right path. You want to add something? It is very easy to laugh on somebody. Okay, or give a smirk. It is very easy. But when you are in the same position, no, it is very difficult to face those situations. Sorry? Yes, that is there a particular name for that, madam? If you know, there is a name for that. It's called Batson's venous plexus. You're correct. Can you repeat what she told? You only, man. So why? Sit down. You too sit down. So what is Batson? What is so particular about this Batson's venous plexus? That it has been thought of causing spinal tuberculosis? There should be some reason, right, that this has been told to be causing spinal tuberculosis, and people would have thought about it, since TB is not a disease of last 100, 200 like COVID. COVID came out of 5 years back. Before that, there was no COVID, right? But TB has been there for hundreds and thousands of years, and people have been studying it for a long time, and people have thought about it also. You know or you don't know? Sorry? More amount of? No, it is not like that. Then sit down. Sit down, sit down. So this is a Batson's venous plexus. Okay. The thing is, Batson's venous plexus doesn't have valves. And this Batson's venous plexus is present around the vertebra, spine. And it is directly communicated with the thoracic cavity and abdominal cavity. So anytime the pressure increases in thoracic cavity or abdominal cavity, the blood gets pumped into this venous plexus. If there is a source of disease in, say, lungs or intestine or kidney, the mycobacteria which are there in thoracic cavity or abdominal cavity will be floating around in this blood. When you cough or when you strain for stool, the pressure increases and this blood gets pumped into this venous plexus, and through this venous plexus it spreads into the spine. Okay, because there are no walls, so the blood flows freely. That is a hypothesis. Okay, the same hypothesis is what is being applied for spine metastasis also. When we say metastatic spine disease, why it is more common? So spine is the most common site for bone metastasis also. It is not the long bones, it is the spine which is the most common site. The reason again which is thought of is because of this only. If you have any malignancy of solid organ malignancy like a lung malignancy, intestinal malignancy, renal malignancy, the metastatic cells which are floating around in your blood will have more chance of going into spine and getting deposited over there because of this reason. Because when the pressure increases, they get pulled into the Batson's venous plexus, they have more time and they can catch on to that vertebra, grow and cause disease. Okay, so this is the whole pathophysiology around it. So these are the destructions, types of destructions of tuberculosis. Anybody wants? Yes, buddy. So what do you understand by the diagram? Read the diagram now. There are 4 types, right? Fragmentary. What do you understand in fragmentary? The diagram itself is saying something, right? The whole body of vertebra is destroyed. That is fragmentary. Okay. Then the other one, subperiosteal. What do you mean by that? What is periosteum? Periosteum is a connective tissue layer over long bones and vertebra. Okay, which provides blood supply and nutrition to the cortical bone, and it takes part in healing process also. Okay, it has nests of osteoclast and osteoblast. So periosteal means the disease which is there, no, when it manifests, it will cause abscess below the periosteum, but it will not be infiltrating the bone. Okay, then next one is osteolytic, means bone destruction, correct. Then so why in one part it is osteolytic and another part it is sclerosis? Sit down. Anybody? Specs. You only last row. Third one. Yeah, stand up. What do you mean osteolysis? Sorry, talk louder, or you, if you want, we can give you a mic. Lysis means destruction. Scoliosis. Sorry, bony tissue. What happens when you get infected and what happens when you are diseased? What is the difference? See, I will tell you two sentences. I am infected with tuberculosis. I am suffering from tuberculosis. What is the difference? You also came directly to the final year. थर्ड फर्स्ट नहीं पढ़ा ना, नहीं सेकेंड ईयर पढ़ा. What is the difference between infection and disease status? What do you mean by infected? You, last row. Yes. Talk louder. Organism gets entered into the body and correct. And what do you mean by disease? Symptoms are caused or it causes local pathology. Correct. So why somebody will develop infection and somebody else will develop a disease? What could be the reason? Sorry? No, incubation period is infected is okay, manifestation of disease is okay, but some people, COVID, you were there, right, around COVID, or you were out of India or out of the earth? You were here around only, no? So COVID, few people got infected but didn't suffer from the COVID disease itself. Few people got infected and suffered from COVID disease also. Correct? Many people are positive but didn't manifest any symptoms, right? What was the reason? Immunity, correct. See, for any disease process to start, it has to fight off the immunity first, right? The body is going to fight off any foreign body or any foreign organism. If it is able to win that fight, you will get infected but you will not have symptoms of the disease or you will never develop a disease. Day-to-day life also you will develop cuts, you will have some injury, but not every time you get infected, right? Most of the time your wounds heal by themselves. This is basic, right? Sit down. This is something which is taught in first or second year. What are the components of immunity? The types of immunity, right? You read? Huh? And it plays a role in pathogenesis of tuberculosis also. Correct? You know or you don't know? Okay, where does the mycobacterium tuberculosis bacteria survive? When people develop infection but they don't manifest disease, the mycobacteria goes and hibernates in some part of body, right? and it is similar to all other mycobacteria, even mycobacterium leprae also. If it is not manifesting disease, it will go and hibernate in somewhere in your body, right? So where it will hibernate? Anybody? You only, why? Oh, very good. Come here, please. All three of you. No, please come here. All three of you, please come here. Sit over here. There is a lot of space over here. No, if you are not able to hear, na, please come here. You also. Please. There is a lot of space over here. Sorry? Sorry? Upper lobe of lungs. Okay. Which book you have read? Which book you have read this? Which book? You are so confident, right? So tell me the book which mentions this. You also parachuted directly in final year. Which book? Pathology, microbiology, PSM. In which book you have read this concept? Or medicine? Or surgery? Or orthopedics? Which book says like this? Okay, tell me what are the types of immunity? Acquired and innate. And what are the components of immunity? Huh? So there is something called humoral immunity and cellular immunity. So what do you mean by humoral immunity? Plasma cell থেকে কি হবে? Antibodies. কত type আছে antibodies? Now we are all talking really basic things, right? Physiology. I think this would have been taught in physiology, right? Tell me the types of antibodies. You people know diagnostics, right? Or that also I have to teach you people how to diagnose tuberculosis. This is all part of how you treat a disease. Why you need to know these things. You people know, right? Why we are talking about immunity and all. There is something called quantiferon gold t-test. What is it? And there is something called PCR. There is something called GeneXpert. You know, right? And there is something called NCAT. So for diagnosing a disease, you need to know, right, from where you are going to take the sample, how you are going to process it, what will affect your outcome. Yes. Types of antibodies. No. Type C. Don't tell me what you know. Tell me what I am asking. Do you know or you don't know? You don't remember. Very good. So what about cellular immunity? If you see, it is very simple, right? Don't waste everybody else's time. You have come here for time pass. Everybody else is not coming for time pass. Even I am not coming for time pass, right? If you know, you tell I know. If you don't know, tell I don't know. I will make you sit down. Because I need to know how much you people know. Because these are basic. I am assuming that you people know about these things. As an orthopedic surgeon, I am supposed to teach you orthopedic principles. I am not supposed to teach you the basics of diagnosing tuberculosis, the immunity part, the pathogenesis part. Because I am assuming since you have come to final year, you will be knowing these things. So which immunity plays a role in tuberculosis? Cell-mediated immunity. So, does it have any role in prevention of TB? How? What do you do for preventing TB? What do you do for preventing tuberculosis? BCG, correct. And recently, there's something, I think you people have read the news. 2 days back, one article was there in Prevent TB trial was conducted in India regarding 2 new vaccines. That's why if you don't know, no, you have to supposed to sit in front so that at least you understand these things. Otherwise, you keep on sitting over there, you will never understand. You don't even know what is immunity, where TB bacteria grows, where TB bacteria hibernates. Mycobacterium leprae, yes. Mycobacterium leprae is part of the same family, right? That also causes chronic infections. Some people get infected, some people manifest with disease. So it has the same playbook. Only thing is the cell in which it hibernates is different. So where it hibernates, perineural cells are there, no, for leprosy, where the bacteria hibernates. And tuberculosis bacteria, macrophages. Macrophages ingest the bacteria, but they are not able to kill it. The bacteria survives in that cells. When the immunity goes down, the bacteria starts replicating. Correct, no? People have read this, right? That's how when you may have got infected in your teens or at a very young age, but the manifestation of disease may happen when you are older, when your immunity goes down. Correct? That's how TB manifests. It is not necessary that you will get infected and immediately you will present with disease. You may get infected maybe 10, 20, 30 years back, but the manifestation may happen today once your immunity is down, because the bacteria is not walled off. Your immunity is not able to control that infection now, which it was able to do previously. Understood? Able to hear? So these are types of spinal tuberculosis. The earlier slide which was there, it was about the vertebral destruction types. Okay. Just because the vertebra is getting destroyed doesn't mean it is a particular type of TB. See, morphological types are also important, because based on morphological type of disease, you understand how you're going to, what are going to be the symptoms of the disease and how you're going to plan on going about treating it. Okay. So morphological discussion is also important. So sometimes, most of the times what happens, it causes the disease starts in the end plate of a vertebra. How many vertebrae are there? Babu, stand up please. We are reading, discussing about spinal tuberculosis. So tell me about spine. 33. Cervical, how many? 5. Very good. Then? Then? Okay. What? Cervical 7, thoracic 12, lumbar 5, then 5, 5. So sacral vertebra. So sacral vertebra separate or it is a single fused bone? एज के साथ फ्यूज होता है. So in children you are saying sacrum is separate. That's what you mean to say. Correct? Am I understanding correct or not? So according to you, in children the sacrum vertebrae are separate, and by the time the skeletal matures, the sacrum becomes a single bone. Come here. You able to see that image? Point out the vertebrae. The upper one, right? This one is the this. Okay. So point out. Okay. Everybody is able to see, or anybody wants to go in front? ठीक है. हाँ. कहाँ? वो तो नीचे आ गया रे तू. हाँ. I think the fifth image which is there, no, the anatomy is better in that. You will able to see. हाँ. So where is sacrum? है sacrum image में. दिखा तो तेरे को मैं. This no. This is sacrum. Sacrum is a single bone. Segments are there. Sacral segments are there, but they are fused even at the time of birth. Okay. Sacrum exists as separate segments only in embryo. At the time of birth, sacrum is a single bone. Okay. And coccyx? तो कितने रहते हैं? सेगमेंट्स कितने रहते हैं कॉकैक्स के? सही है, करेक्ट. ओके. सो अब बता कितने वर्टिब्रा हो गए? और फॉर डिजीज पर्पस sacrum is usually considered single vertebra. Okay. ठीक है. 26. Coccyx is also considered single vertebra. अभी याद रहेगा? ठीक. बैठ जा. See, don't be afraid. Why I want to point this out is because you people I don't know whether you know anatomy also or not. That's why I just wanted to confirm. सही ना? So in a vertebra which is there, no? This is the body of the vertebra if you are able to see. Are you able to see? This is the discal space. Okay, and these are the end plates. This is the upper end plate of the inferior vertebra and this is the lower end plate of the superior vertebra. In this you will be able to see. So these are the end plates. This is the vertebral body. This is pedicle. This is posterior part of the spine. This contains lamina and spinous processes. Okay, and these are facets. This is inferior facet of the superior vertebra. This is superior facet of the inferior vertebra. So most of the time disease starts in the paradiscal region, in the end plates. Okay, because end plates have cancellous bone, it has good blood supply. So the bacteria starts developing over there, causes disease over there. Sometimes what happens, the disease will start anteriorly beneath the anterior longitudinal ligament, where there will be a tuberculous abscess will be there. That is where the bacteria is not invaded the bone per se, but in the surrounding soft tissue. The anterior longitudinal ligament, the surrounding connective tissue which is there, the bacteria will be dividing and producing pus that will lead to symptoms. Then sometimes it is only in the posterior part of the spine. Okay, only the spinous process or the lamina or the pedicle gets involved, and sometimes it is in the center of the vertebra, which is pretty rare. Okay, so why is it important? So spinal tuberculosis, what do you expect? If a disease process happens, what are the symptoms which will happen? This we had discussed last time, right? Yes, madam. Spinal tuberculosis, if somebody is suffering from spinal tuberculosis, what are the symptoms patients will be suffering from? Correct. Then? Sorry? No, it is not due to pain the patient suffers from fever. The patient suffers from fever because he has an infection of tuberculosis. And the TB fever is particularly defined as something, right? How is the TB fever defined as? So no, fever night sweat is there, but what about the fever? Whether it is high grade, low grade, any particular time of day, evening rise of low grade fever. That is how it is defined, right? Tuberculosis. If it is high grade, you are going to suspect what? Some aerobic infection. If it is low grade, been there for a long time, then first thing which you think of is tuberculosis. Correct? So besides that, pain ho gaya, fever ho gaya, then what else the patient suffer from? Night sweat he has told already. And any particular diurnal variation in pain? Is there or is there not any diurnal variation of pain? Yes, madam? If a patient is suffering from tuberculosis spine, does the pain symptom have any diurnal variation? Yes or no? No. Okay. What about everybody else? Yes. Stand up and say. Night pain, night cries. So why night pain? You are correct. There is a diurnal variation. Okay. Usually patient will suffer from night pain. Why? Sorry? Correct. See, you have to stop thinking that the structural components which are there in the body, they act in isolation. Like now, since we are talking about spinal tuberculosis, you people think that the bacteria grows in spine. So everything, the symptoms, the disease process, everything will be affecting that vertebral column only or that bony part only. It is wrong. Any disease, when it happens, it affects the whole structure itself. Okay? Like lungs, when you say pulmonary tuberculosis, when it happens, it is usually associated with TB lymphadenitis also. You will have viral lymphadenopathy. Okay, so it's not just the lung parenchyma which will be diseased, the glands which are draining it, the lymph nodes, they are also going to get affected. And the reaction to that infection, the fibrosis which happens, the empyema which happens, that is going to cause clinical symptoms. And that is what you are going to treat. It's not like every patient is same, right? Some patients, like he said, upper lobe of lung TB happens. Some people will have the whole white lung, the whole lung parenchyma will be involved. There will be effusion. There can be empyema. There can be secondary bacterial infection. There can be lung fibrosis, which may ultimately lead to what? COPD. Okay. So when you're thinking of a disease, and even though we are talking about systemic features or localized disease presentations, it never happens in unison. The fever which happens, it is a systemic feature, right? The disease is in the spine only. Most of the time what happens, extra-pulmonary tuberculosis which happens, the disease vertebra is there, that might be the only source of bacteria for the body. But the symptoms which are manifested are throughout the whole body. The fever which happens, it is not like there will be local rise of temperature at the site of the vertebral infection. The temperature of the whole body rises. Same way the malaise which happens, the low appetite which happens, it affects the whole body because that is part of inflammatory process of the disease itself. So stop considering the local site. Think of the patient as a whole. Okay, the disease when it happens, it's going to affect the whole patient. It is not going to get restricted to that particular site. So that's why when you're talking about clinical features or clinical manifestation of a disease, you have to consider the local symptoms, you have to consider the systemic symptoms. The local symptoms are those which are caused by the disease process, the destruction caused by that pathogenic agent in that local area, which will lead to what she said, night pain, night cries, okay, sometimes spasms, muscle spasms happen. If the disease invaginates into the canal, vertebral canal, and causes cord compression or nerve root compression, patient will have neuropathic pain or paralysis also. These are because of local symptoms. But what about systemic symptoms is what he told. The night pain which is there, it is not because the disease is causing local destruction. It is because the disease, the bacteria is causing inflammation, it causing an inflammatory response in the whole body. The malaise which happens, the low appetite which happens, it is because of the systemic effect of the disease. So please consider these things when you're talking about a disease. Disease never, even pathogenic agents never work in isolation. They cause local symptoms, they cause systemic symptoms. We are here in the business of treating the patient, not the site of disease. So you have to consider the whole patient itself. And even with the same kind of disease, the manifestations may vary because of individual variations, because of the pathogenicity of the bacteria, because of the immunity of the patient, because of other systemic disease which the patient may be suffering from. If a patient is a diabetic, the symptoms, the disease process might be very fast. Compared to that, a young patient whose immunity is not compromised, the presentation might be much more less. Okay. This I think is the crux of this. Why tuberculosis is taught to people? You understand? Do you understand why? It has been taught to you from I think first year to the last year. Correct? In some form you will be reading about tuberculosis every time. One reason is it is a major public health problem. Even today, after 75 years of independence, we are not able to eliminate it. 1/3 of our population is infected. Many of them get manifestation of the disease. And the way this disease behaves, it is very difficult to treat. So, put your brains in this. Think about disease in this sense. Now you are just 1 year from passing. Okay. Just don't read it as a topic. Think of it like a disease process. When you're talking about a disease, you need to know about what is the infective agent, what is the pathology, how it is. भाई तू बैठ जा, काफी देर से खड़ा है, बैठ जा. Sit, everybody sit. Okay, that is why it is important. See, final year is supposed to be, see, what I understand about final year is that you people have read pathology, microbiology, you know of the immunity part, you know about the diagnostic part. Now we are here to teach you how all these things combine, cause the symptoms in the patient, lead to disease process, cause the manifestation, or how you are going to tackle it. Correct? The pathology part would have been taught to you in second year. But that doesn't mean just because it has been second year, you need to keep on reading it again and again. Because this same pathology you are going to treat for maybe next 25, 30, whatever the length of your practice will be. And pathology is not going to change. Anatomy is not going to change. Modalities of treatment may change. The way we treat a disease may change. The way we try to prevent a disease may change. But the basics, they don't change. The way we are investigating, the way we are helping the patient rehabilitate may change. But the basic things never change. They have been same when I was studying. They have been same when your senior teachers might have been studying. Only thing is we are knowing certain new things every year. You have to get updated with these things, but then it doesn't mean just because you are getting updated, you need to forget what you have read previously. So we have talked about this. So basically the local destruction which happens, we will discuss about the local symptoms, we will discuss about the systemic symptoms. The local symptoms, when they worsen, when the destruction happens, it will lead to deformity. Okay. So in spine, what deformities you are thinking of? Correct, man. जोर के बोलो. Kyphosis. Then scoliosis. Kyphoscoliosis can also happen. It can be a combination of kyphoscoliosis. It can be a 3-dimensional problem also. Okay. So these are the things which happen. Paraplegia, I think you know this classification, right? Quantification of paraplegia, stroke and spine injury, it's the same. This we had discussed last time also, right? Nahi? Yes. Second last row. What is the difference between paraplegia and paraparesis? This is still anatomy and physiology. Paresis means, sorry, paresis means weakness. So what muscle power, you know how you grade muscle power? How? Grade 1 to? So what is grade 5? Sorry? Against maximum resistance or against reasonable resistance. मैक्सिमम नहीं होता रे, तेरा तो एक्सएम अलग होएगा, मेरा अलग होएगा, इस भाई का अलग होगा, वो पीछे बैठा हो उसका मेरे से भी ज्यादा होएगा, नहीं है कि नहीं? It is not quantified like that. It is reasonable resistance. Okay. Then grade 4. What? What is grade 4? Sorry. Moderate force. Grade 3 is against gravity. Grade 2 is when you negate the gravity. Grade 1 is only flickering. Means muscle contraction you are able to feel or see, but actively there is no movement happening at the joint. That is grades of motor power. Sensory. बैठ जा तेरे बाजू वाला. Stand up man. Specs. Sensory examination. What all you check for? Touch, pain. What are the types of pain which you touch, which you differentiate? Deep pain. Then something called 2-point discrimination is there. You check for it or not? What is paresthesia and what is anesthesia? That is hemiparesis, quadriparesis, monoparesis, what you are talking about. We are still in sensory examination. Means you are giving a stimulus for pain. Patient is, instead of feeling pain, patient is feeling touch or patient is feeling hot. The sensory stimulus which you are giving is not generating the appropriate response. It is deviating from the normal response and creating some other response to the patient. Anesthesia means when you are giving any stimulus, there is no response being generated. Even if you poke a patient, he is not able to perceive that sensation. Okay. So why is it important? Now you have to come to the anatomy part. Why is it important? Sit. Yes. You only. Why is it important? Besides you. Again, now we have come back to anatomy of spinal cord. Yes, madam. Why do you think it could be important? Correct. No, that we have established that we are going to check for motor power. We are going to check for sensory power. Now we are in grades of classification of paraplegia. See, just 5 minutes ago I told you, that each patient is going to be different. The manifestation, the presentation of the patient may be different. Some patient may have only sensory symptoms. Some patient will have motor plus sensory symptoms. Some patient may have only pain. They might not have any sensory or motor symptoms. Correct? So what could be the reason for that? Think about anatomy. We had seen, no, paradiscal disease is there. There is anterior disease there. There is vertebral body disease is there. There is posterior spinal process disease is there in tuberculosis. So what happens when the site of disease changes? Symptoms change, correct. So how is it going to change? Okay, let's think of it in this way. Spinal cord which is there, no? Where does it lie? With respect to vertebral body, where does it lie? Inside vertebral, that is correct. Okay. So where is the vertebral column? And where is the spinal canal? That is spinal canal. The body forms the vertebral column, the body and spinous process. You're correct, spinal canal is there. So where it is near to? Relatively speaking, the spinal canal is not in the center, right? If you see the diagram, the spinal canal is lying more posteriorly. So which patient do you think will have more involvement of cord or neurological involvement? Which type of disease? Again, I will think. So a disease is lying over here. It is involved in the spinous process. It is involved in the lamina. It is involved in the pedicle. Does this going to cause neurological symptoms or a disease which is lying subperiostally or in the vertebral body? What do you people think? Correct. So posterior disease, if it happens because it is lying more close to the spinal cord, if there is an abscess, if there is a destruction, if there is an inflammatory reaction happening, then it is going to cause spinal cord compression earlier, right? That's how you define, that's how clinically you check for disease site before even ordering an X-ray or before even thinking about investigations. Which part of the cord might have been involved. The whole purpose of teaching you people is this critical thinking only. Once the patient walks in, it is not like directly you have to order investigations. You have to first examine the patient, right? So when you're going to examine the patient, there are going to varied presentations. Some patient may have only sensory symptoms. Some patient may have only mechanical pain. No, there will be no sensory or motor symptoms. Some patient will have a visible kyphoscoliosis or a kyphosis, which will directly tell you that the site of pathology might be in the thoracic or thoracolumbar junction or even a lumbosacral junction. Some people might not have any signs or symptoms of disease itself. So how you are going to decide what part of the disease vertebra is involved? Your clinical examination is going to tell you that. And for that you need to quantify your symptoms, quantify your signs, quantify your clinical examination. That sensory examination, what is the finding, whether the touch is gone, whether the 2-point discrimination is lost, whether the temperature difference is lost, because these are the different tracks, correct? Different tracks carry different sensations, different tracks carry different control, motor control. The site of the disease causes compression and that will lead to manifestation of the disease, right? So that's why we need to read it. So that's why in this sensory, see, you see this thing, lateral column involvement, lateral column, both lateral and posterior column involvement. So if lateral column is involved, what is this? Lateral column is there is something called corticospinal tract, there is spinothalamic tract. कितना time हो गया? We have to finish this today, okay? You go read. कौन सा क्लास है? होने वाला है? हाँ तो रुक जा 5 मिनट, अभी खत्म करते. Okay, this we had already discussed, right? Pre-destruction means, see, that's what I'm saying, na? You need, if you if you think about disease like a process, right, you need not read or mug up everything. This is how the disease progresses, right? We have been discussing the same thing, that some patients will have only dull back pain, they won't have any sensory symptoms. As the disease progresses, the symptoms will worsen, the patient will have sensory involvement, the motor involvement. That's how the disease process is quantified, that where there is something called early stage disease and the advanced stage, right? So that's how you quantify it, based on symptoms of the patient, based on the destruction of the vertebral column. And that will determine your treatment also. A patient who is having only localized disease without any structural involvement is not a candidate for surgery. Surgical indication in spinal tuberculosis is very less. Okay, early stage disease is treated by drugs and it gives excellent response. But a patient who is having a visible deformity or who is having neurological symptoms, more often than not, he may require a surgical intervention. So choosing a patient who will benefit from surgery or choosing a patient who will require only medical therapy is very important. You are supposed to guide your patient, right? How are you going to tell him, भाई आपको थोड़े दिन में सर्जरी भी लग सकता है या आपको सर्जरी की जरूरत नहीं पड़ेगा, आप दवाई खाओ 6 महीना 9 महीना आप सही हो जाओगे. So it depends on these things. So diagnosis, pulmonary tuberculosis you diagnose by sputum, chest X-ray. What is CBNAAT? So it is kind of PCR. Any other PCR? Any other PCR you know of for respect to tuberculosis? GeneXpert, correct. GeneXpert is it. So previously, means about 15-20 years back, the guidelines were different. Okay, you have read this NTEP. When I was a student, we used to have RNTCP, Revised National Tuberculosis Control Program. At that time, the disease burden was so much, we were not thinking about elimination. We were thinking about control. Okay, so there was a category called presumptive diagnosis of tuberculosis. And people used to start TB drugs. Even today, people do that. Now, in this era, where CBNAAT, PCR, GeneXpert, biopsies, histopathology examination is available at every center. Previously, what used to happen is CBNAAT and everything was available in dedicated centers only, government mandated centers. Okay, so that because this facility was not available, a person who is going to treat somebody in a village or say a taluka level, where these facilities are not available, they had to make a diagnosis, they have to start treatment. And because the burden was so much, we used to make a presumptive diagnosis that based on the clinical symptoms. The patient is having evening rise of temperature, he is having low back pain, X-ray shows some vertebral involvement, but most of these patients will not have pulmonary manifestation. So you cannot do a sputum test to check for tuberculosis bacteria. But then you can make a clinical diagnosis and start him on NTEP drugs, wait for few days to see whether the patient is responding to treatment or not. The fallacy with this is, tuberculosis is a very weird bacteria. It's not like your Staph aureus or Streptococcus, where you give antibiotic for say 3 or 4 weeks, the bacteria goes off and the patient gets cured. Tuberculosis has a very different ways in which it can generate resistance, and the drugs which we have available even today are very few which actually work on this. The reason is in its particular nature, where it lies. It is intracellular, so most of the drugs might not reach over there. Okay, when it is in hibernation, and when it is manifest also, because it is a low metabolic rate, so many of the drugs which we routinely use for other infections, like penicillin group of drugs, they don't have any effect on it. It is by design, it is resistant to that. So when you give drugs without testing for resistance, the chance of this bacteria developing resistance for the drugs which you have already given is very high. This, you know about MDR-TB and XDR-TB, right? What is MDR? So which two drugs? And what is the definition of XDR-TB? No, it is extremely drug resistant, but again, there is a way of quantifying it, there is a definition. It has to be resistant to isoniazid, rifampicin, and one second line drug, right? One of the second line drugs, fluroniculin or something, it has to be resistant to. That is extremely drug resistant. And what is TDR? Totally drug resistant TB. Nothing works. It is rare, but it is there. Okay. So these things you need to know. Now when you're going to go for medicine exam, no, Viva, these are questions which they are going to ask. These are the basic definitions which are there. Because TB is there as part of your curriculum for medicine also, for surgery also. And these programs, this pathology helps you everywhere. So for spinal tuberculosis, you need to have a tissue diagnosis. We are just going to complete it. For spinal tuberculosis, it is not like you're going to do a sputum test, you're going to do a chest X-ray, you're going to do a vertebral examination and done. You need to have a tissue diagnosis. And when you're doing a tissue diagnosis, more often than not, you're going to do a nucleic acid amplification test, either a CBNAAT or a GeneXpert, to know the resistance pattern. Because if the bacteria is resistant to rifampicin, then you're not going to give rifampicin, you're going to switch over to other drugs. Otherwise, these are very difficult to cure. First of all, it is not like a routine infection where you can just go in, clear it out and hope for the immunity to work. These patients are already immunocompromised. So you don't depend on immunity for the infection to get cleared out. You need to help it. And you need to use particular drugs which are already limited in number. What is the latest drug which has been added in TB program? Anybody? Correct. Beta-glucan is the latest drug which has been added. उसको पता है, पढ़ के आया वो. What are the other drugs? Usually what we give? There is intensive phase, there is maintenance phase. So, what are the categories of tuberculosis treatment? NTEP program. How many categories of patients we quantify the patient into? पता है? Previously there used to be 3. Now, why? Thought about it? नहीं. पहले 3 था, सरकार ने 2 कर दिया, ऐसे ही. The reason is it is very difficult. The third category which was there, no, it was relapsed TB, and the definitions were very vague. So more often than not, the categorization of the patient used to be wrong, and it used to create unnecessary confusion, because based on that categorization, the patient is going to get treatment. Either you end up in a 6-month regimen, or a 9-month, or a 12-month, or a 18-month regimen. Okay, so what is the regimen for bone tuberculosis? Anybody? How many days the treatment starts? Treatment persists? Tuberculosis, usually when a newly diagnosed TB patient, how many months the patient gets treated? 6 months. Bone TB is not like that. It can be 12 months, and at the discretion of physician, the treatment can extend to even 18 months. Okay, because the site, the lesion which is causes a lot of fibrosis. The bacteria can be walled off within that fibrotic capsule. So to clear the infection, you need to give prolonged duration of antibiotics. Okay, lung has dual vascular supply. There are very few organs in the body which are dual vascular supply. Lung is one of them. So because of good vascular supply, whatever drug you give, maximum drug is going to get circulated to the lung only. Heart is going to pump to the lung, and all the drug which you have taken will be going through that circulation. But spine is not going to get all the blood supply. So the drug which you consume, not every 100% going to reach that spinal area. So indication for surgery, I told you, not every patient is a candidate for surgery. Not every patient we operate. If the patient has diagnosed TB, but there is no neural compromise, there is no structural instability, and the patient is probably going to respond to treatment, he is not a candidate for surgery. Surgery is reserved for very few indications. Either the patient has a neurological deficit which is progressive, or there is a visible deformity which is going to cause late neurological compromise. TB causes early neurological compromise. There is something called late neurological compromise. This thing also you have to understand. Patient might get cured of TB. Okay. Today the patient is completed treatment, you have declared him cured of TB, but 2 years, 5 years, 10 years down the line, he can develop neurological symptoms because what he told, Scoliosis, the deformity which the patient develops over a period of time, it worsens and it causes secondary neurological compromise. This secondary neurological compromise may manifest with weakness and sensory deficit. So even a cured patient may end up with a surgical intervention at a later date after he has been cured of TB. So that's why you need to be aware of these things, that sometimes the patient, that's why history is important. When we see patients for low backache, we have to always be asked whether TB ka history hai kya? Because either it can be a reactivated TB, patient may have a pulmonary TB, patient might have reactivated his TB and now the manifestation may have been in spine, or patient has been a cured case of TB which has healed, but now because of the secondary vertebral compromise, the patient is now developing neurological symptoms. So those are the conditions which you have to evaluate the patient for surgical management. Understood?